Yes.
Perfect.
Yes.
Okay. We'll give it like 2 to 3 more minutes, then we can get started, because I can see others are coming. Most of the time we plan it on Thursday, so most people, they get used to have it on Thursday, but sometimes if the guest speakers is not available, so then we'll see which day work best for them. So
Yes, sorry, my diary at the moment is a challenge.
no problem. But as I said, whoever who registered, we send them the recording later on.
Okay, yeah.
Okay, we can start in 1 more minute at 9:03. This is what I have here. Okay, so let's get started. Good morning, good afternoon, everyone, and thank you for attending today's webinar series. Today's talk is going to be by Dr. Sarah Bauermeister and moderated by Sydney Lowley. So the floor is open to you, Sydney, to introduce our guest speaker, Sarah.
Excellent. Thank you so much, Latifa. So just a minute or two on Sarah. I am so excited to introduce her and moderate the Q&A today. And I'll just say in advance, please enter your questions into the Q&A, into the chat, and we'll manage those questions at the end. And we'll welcome you to speak up and ask your questions in person as well, if you're comfortable doing so. So about Sarah, who I get to introduce today, she's a cognitive neuropsychologist and epidemiologist. I think a lot of you are very familiar with her and her cross-functional work, multidisciplinary, certainly one of those I call magical people that have data science savvy as well as people skills. And so this has enabled her to really accelerate her work in the Dementias Platform UK, or DPUK. And this, of course, is what she'll talk about today. This is a cohort repository with over 60 cohorts and over almost 4 million samples, 4 million participants. And of course, neuropsychiatric cohorts are of extreme interest to pharma that I see in my work. So one more thing I'll say about Sarah, something that I really appreciate about her is her commitment to mentorship. And she leads the training program and scientific review for DPUK. And as she's doing here, she represents the DPUK internationally. So with that, please welcome Dr. Sarah Bauermeister.
Thank you very much, Cindy. That was very kind and nice introduction. Thank you so much. So that's enough about me. So as Cindy said, DPUK is a data repository for over 60 population and clinical cohorts across 3.5 million individuals. Now, importantly, these data sets have not been collected for dementia. They could perhaps be healthy birth cohorts, healthy population, cancer, cardiovascular disease. But by depositing them with DPUK, researchers in dementia and neurodegenerative disease and mental health are able to access these data sets for their research purposes. So I will start going through the slides. So why do we need a data repository and why do we need DPUK? Well, by the time someone comes into a clinic in primary or secondary care, and they feel that they have cognitive changes or memory impairment, unfortunately, the disease has already been present within their brains for 15 to 20 years prior to that. And in order to identify treatments and new clinical remedies for dementia, we need to understand what happened in these individuals' past. And by accessing real-world evidence data or population, clinical and birth cohorts, we're able to look back in time and see what was this person's lifestyle like, what was their mental health like, what was their early life like, what did they eat, what did they drink. And so this is really where a data repository like DPUK has come into its own in being able to elucidate more understanding about the earlier preclinical signs. And this is really important for pharma to understand using prediction models, this preclinical time. So a little bit about DPUK. I'm talking today about the data portal. We do have an experimental medicine incubator. We have a trials registry, but today I'll just talk about the data portal. We have had over 1,345 data set requests. We have 965 registered users across 102 institutions, and importantly, 44 countries. So this is really a global platform. So it doesn't matter whether you're in Australia, Malawi, the UK, you can access these data sets through a simple internet connection. And the decision time, the median time on providing these data sets for researchers is just 22 days. And we have both survey, imaging, and genomic data. These are our partners, and I'm showing you this right in the beginning rather than here at the end. I acknowledge these because without these partners, excuse me, we would not exist. So we are funded by pharma partners, industry partners, philanthropic partners, and industry and academic partners. And we're in our second term of funding, and we hope to carry on further. And of course, MRC, the Medical Research Council, which provide 50% of our funding. So this is the data portal. This is what researchers see when they come along and they come to our website. They can see on one page how to discover, access, and analyze cohort data for their specific research question. We provide them with data discovery tools. So they come along to our cohort matrix where all our cohorts are listed on the left-hand side with very basic information such as age at recruitment, participant number, gender, start date, and how they can access the data. And then using our ontology, which I'll speak about a little bit later, all of our data sets are categorized into our ontology, 18 categories of data. So researchers can come along and have a look, for example, just presence or absence of that category of data within that cohort. Then we have our cohort directory. So having identified cohorts of interest in the matrix, they then come along to the cohort directory to find out additional longitudinal information. So here they can click on it, and here's an example of ELSA, which is the English Longitudinal Study of Aging. And you can see again our ontology on the left-hand side, and I've burst open here mental health status. And you can see that we then give them the subcategory, the variable type, which scale has been used, and which wave points it's been measured at. So we're hoping that researchers come first to the matrix, then to the directory. By the time they apply for their data set of interest, they are applying for appropriate cohorts to answer their research question. They fill in a full project proposal, which we scientifically triage, and then it goes out to the cohorts to decide whether they access the data set or not. DPUK does not own the data sets. Once they've had at least one cohort approved, so even if they apply for 10, they have just one approved, we set them up with a DPUK account. They log into the portal, they're at number 1, they acknowledge the data access agreement, which they've signed. Number 3, we give them a login name and a password, and then the 2-step authenticator through an application on their phone, and then they can log into their desktop, which we've provided them. And we have a small or a standard, a large and an extra large according to their analyses, which they've proposed. So if they're going to just do multiple regression, hierarchical regression, then a standard is quite fine for them. If they want to do a bit of machine learning and more complex modeling, we'll give them a large desktop, which is 32 gigabytes. And then if they want to do the more complex structural equation modeling and deep learning, we give them an extra large desktop. We also have a Linux desktop available for genomic and imaging analyses. This is the desktop, so it looks very much the same as if someone had the data downloaded onto their desktop. However, they cannot download the data. It's a closed environment, and we simply switch the data sets on for the ones that they've applied and have approval for. Inbuilt into the platform is all statistical software, whether it's R, MATLAB, Python, SPSS, SAS, Stata, and FSL for imaging and Plink for genomics. We have included all of that within the data portal. So this is an example of my projects. I have a lot, which, as Cindy said, I'm multidisciplinary and I tend to get involved and have ideas about everything. But this is an example from one of my projects on childhood adversity. I've burst open that to the side. And you'll see within that project folder, I have both DPUK and non-DPUK cohorts. So the advantage of DPUK is that if you have access to data sets outside of DPUK, you bring it in, you put it into your secure project folder, and then you simply remove it again at the end of your project. So it doesn't stay there, DPUK doesn't take it over. And all my collaborators working on this project, no matter where they are in the world, can access this folder and this folder only. And then they have their own user folder as well. So it's a very collaborative way to work, and it's very good for early career researchers who don't have the funding often to access these large cohort data sets. So what can researchers do if there's no internet? Well, we ask them not to take photos of the raw data and share it on social media, but they can take out their models, their output, and their metrics and their code. And this is for publication and presentation purposes. Likewise, they can upload their code. So they're able to, if they've got code on their desktop, they're able to load that into the environment through a secure portal. We do have a paper if anyone wants to know more about DPUK. So a little bit about our model and why it's important to us. So the model is 18 categories. It feeds in the categorization of our data from our cohort owners. So if our cohort owner says, well, all I've got is 20 SPSS data sets, or someone says, I've got CSV, and only a few say they have paper now, but we don't turn paper away. We do the work. So my data curation team, I lead data curation for DPUK. We categorize it into these 18 categories. Below this, we have 160 subcategories or domains. Below that, we have over 700 families. And then, of course, the object or variable level, we go into the 10s, 20s, 30s, thousands, according to as we build up all our cohorts. What we also do is we standardize the variable name. So we would like all variables across data sets to be named in the same way. Now, this is very time consuming because even if the variable label is very slightly different, we have to give it a new variable name. So this is what we're doing for our cohorts, and then we will give them back the fully curated data set. This is our 30 neurodegenerative disease variables that we harmonize. So over here, we just standardize, but over here, this is our harmonization work that we do. And this is mainly for visualization and feasibility, but we will also provide this harmonized data set back to our cohorts. It's focused on mental health and neurodegenerative disease, and it means that in our cohort explorer, researchers can come along and do feasibility work comparing cohorts with each other, having a look, for example, if they're looking for people with cardiovascular disease who are also smokers and who are maybe just female, they can come and have a look and see which cohorts and what the sample size would be by the time they've requested those data sets. So this is our harmonization work. And again, we have a paper on our CSERV ontology and also our harmonization work as well. So that's enough about DPUK. The important thing is to show how DPUK can progress research across multiple cohorts. So I'm going to present today on a couple of my programs of work that I lead here in Oxford as associate professor, so now with my scientific hat on rather than data management. I run the Blossom program, which is looking at early adversity and brain health. So I just want to acknowledge my wonderful team of postdocs and DPhil students all over the world. I work with them both in my department and also in Romania, in Brazil, in the States, and in Dublin. And we can because we use DPUK. And so why is early adversity important? Why is early life? You know, can we even do anything about what happened to us in early life? So what's the point of looking at it? So what we're trying to look at is the deleterious effect in later life. So it's a broad construct. It includes sexual, emotional, physical abuse, and also deprivation. The multiple adverse experiences, unfortunately, leads into multiple negative outcomes in later life, including depression, lower life satisfaction, dementia, and even morbidity. My work, my program of work, we use all of these cohorts. I think there's 12 or there was 15 here, and they're both DPUK and non-DPUK cohorts. So I apply for them, I get permission to upload them into that folder that you saw previously. This is the folder this is the table that reflects that folder. So one of our projects, which we conducted quite a few years ago now, my postdoc is now writing this up. We looked at 3 cohorts, the UK Biobank, which is also part of IHCC, which is 500,000 individuals, the English longitudinal study of 12,000, and a birth cohort, NSHD, of just 5,000. And we were looking at the impact of self-reported early adversity on later life, biopsychosocial, mental health, and cognition. Now, importantly, the questions about early life are very different across all cohorts. So, for example, in UK Biobank, there is a question that says, people in my family hit me so hard it left me with bruises. But in NSHD, there's the parental bonding instrument, such as mother and father made me feel I wasn't wanted. Again, in ELSA, they ask whether you were physically abused by your parents under the age of 16. And I'll come back to this later to show how we handle very different and disparate measures across cohorts. So this is the Biobank data set. And what we did was we formed a latent construct of childhood adversity, feeding into those questions that reflected physical, emotional, sexual abuse, and also deprivation. And then we looked at co-varying later life constructs, such as biomedical health, mental health, cognition, and also lifestyle. And by using latent constructs, we can then compare cohorts by validation work. So rather than pooling all the cohorts together, it's a frequent question saying, well, how do we combine these data sets? Well, when you have 500,000 individuals, is there an advantage of combining data sets, or is validation work more important? And what we found was we found a negative effect on all of these outcomes in the UK Biobank and childhood adversity. We repeated it in ELSA. And then this time, of course, our measures are a little bit different. So this time we have physical and parental abuse, which was, we created a factor through a PCA. We popped that in as a single measure. And then we looked at deprived childhood, which was measured across different variables, such as how many rooms were in your house, how many cars did you have, how many books were on your shelf. And so we created a factor, and those two factors formed the latent construct. So again, very different to UK Biobank. But importantly, we found similar outcomes, that everything was significant, that early adversity had a significantly negative impact on biomedical health, lifestyle, mental health, and also depression. Now, importantly, that is cross-sectional work. And in order to understand mechanistic pathways and causality, we then looked at some longitudinal models. Now, the model on the left is ELSA UK. And this time we're looking at early adversity, EA3, measured at time point 3, and the effect on adult adversity and also on depression. And then we looked at wave 6, wave 9, and we also looked at cognition, but then mental health during COVID. Now, this work, we found an enduring negative effect. Even when taking into account depression before, we found an enduring negative effect. And in fact, some of the work that we're doing now is part of the IHCC funded program that we ran in the pilot study, is writing up this project and using ELSA Brazil and also TILDA as a comparative analysis to show that people who went into the pandemic with a history of early adversity, a history of poor mental health, their mental health was exponentially affected during COVID because they went into it with an already high stress load. Again, another longitudinal model on the right-hand side. This is the NSHD cohort again, but looking in 1989 on the left, adversity, they were asked the parental bonding instrument. We've extracted out just 2 questions looking at rejection, because at the root of childhood adversity, whether it's a sexual, emotional, physical abuse or deprivation, a child feels rejected. So here we're trying to understand the mechanisms, and we looked at cognition in 1999, 2009, 2015, and also depression. And what we found was, again, that early adversity has an enduring effect on both cognition and depression, and a direct effect on depression and cognition. So that is one part of the Blossom work. We also want to understand what is going on in the brain that is causing these later life outcomes and this negative impact on mental health and cognition. And one way to do that is actually just simply to look at the brain. And another one of my postdocs, Dr. Delia George, looked at the association of perceived adverse lifetime experiences and brain structure, again in the UK Biobank. And we had a sample size of 7,003 individuals who we could use for this study, which is still a very significant high number for those of you familiar with imaging. And she factored out demographics such as age, deprivation, education, ethnicity, and handedness. And also she looked at comparative body size at age 10, height at age 10, maternal smoking, and breastfed as a baby as control variables for her analyses. And I'm going to jump really forward now. And what she found was that people who experienced early adversity had cortical atrophy in the cerebellum and the ventral striatum volumes. And these are both areas implicated in the reward circuitry. So here we had physical evidence that there is something going on in the brain that is causing this later life, let's say, associated with these later life mental health and cognitive outcomes. Now, that previous study, Biobank provide derived metrics of brain imaging. So Delia used the derived metrics, but in this study here, she used the raw imaging data. We uploaded it onto the data portal for her, and she looked at perceived maternal control. And when we say control, this is over control, measured such as invaded my privacy, was overprotective, tried to control everything I did. So it was an almost abusive control measured through the parental bonding instrument. And then the sample size for this was 394 individuals. By the time there were individuals excluded due to missingness, we excluded people with a stroke or any other infarction in the brain. And this is still, again, a very large number to process the raw imaging data. She brought the data onto the portal through the Linux environment, and she converted the DICOM files all using the virtual desktop. So she could have been anywhere in the world doing this work, but she was able to do it on the DPUK platform. And what she found was that well-being was lower in those people who reported higher maternal control. But importantly, there was atrophy in the caudate nucleus and the putamen regions associated with higher maternal control. And this really validates her previous work using UK Biobank derived brain imaging. And here she's finding similar effects, putamen, caudate nucleus, the reward circuitry, that somehow we're digging into the mechanisms of understanding the later life impact of early adversity. Another study, another one of my postdocs conducted, and this time it's a multi-cohort study looking at childhood socioeconomic deprivation. So rather than physical, emotional, and sexual abuse, she focused on socioeconomic deprivation. And earlier studies have shown that on later life, there is a cognitive function, there is a social gradient. So in other words, the more socially deprived you were a person was in childhood, the impact on later life cognition is significant. So we characterize cognitive trajectories using latent class mixed models, and we explored the association between the childhood socioeconomic status and the latent class membership using logistic regression. And the result was that we found distinct trajectory classes for all cognitive measures examined. And childhood socioeconomic deprivation was associated with an increased likelihood of being in a lower trajectory class. So the three cohorts that we used for this was Whitehall 2, 5,000, HRS 8,500, and Kame, which is a Japanese population within the United States. And different sample sizes, different regions of the world. However, we were able to extract out using different measures. Again, we didn't do harmonization work. This was a validation study. So in Whitehall, we had the MMSE, we had phonemic fluency and verbal memory, and we found these trajectory classes. We're not sure what's going on with this deep dive of class 2 in phonemic fluency, but our hypothesis is that with fluency, education throughout the lifespan can improve phonemic fluency. And in HRS, there was a different task, and semantic fluency as well, and Kame, the MMSE. But this work shows the validity of taking populations, different measures, different cognitive measures, but focusing on a similar predictor, such as early adversity. And so this paper has also been published. So this really shows the power of multi-cohort work without the need for harmonizing across all the cohorts. One more, the cumulative, this project was part of Morgan's DPhil PhD in Switzerland. She's now a postdoc in my lab here in Oxford. And she was looking at cumulative life course adversity. So really, what is the understanding between the different type of adversity when it was experienced and the different cognitive domains investigated? This time she used UK Biobank again, and she looked at only 73,000 of UK Biobank because the measures that she wanted to look at was in wave 2 and 3 of UK Biobank, which is a smaller sample size, repeat measures only on a select sample size. She used again the PHQ-9 to look at depression this time and life course adversity using the questions that I presented earlier on. For cognition, she looked at intra-individual variability. Now, what this is if you take part in, this was a SNAP task, and every time they identified something, their reaction time, the mean reaction time, was simply recorded. But what we did was we took the variability in their reaction time. So if it was 300 milliseconds, 400, 500, 300, 400, we tracked that variability, because variability rather than mean reaction time is associated with early neurobiological change. And what we found was that cumulative life course adversity was significantly associated with executive function, as extracted from a trail-making task, B minus A, to get that executive function component. And however, it was not mediated by this variability. So in other words, in this measure, it was not measured by neurobiological change, the proxy which we used variability for. However, it was mediated by depression. And this study is really important for us to understand that perhaps it's poor mental health driving these later life negative outcomes. Now, she's won a 2-year fellowship to come to Oxford to understand these mechanisms further. Oh, and this is her paper that she's also published in Nature Scientific Reports on that study. So I don't know if you want to keep questions to the end, but I'm happy to take questions now and then go on to a bit more. What would you prefer? That I just keep going?
Yeah, please keep going.
Okay.
Because yeah, I asked them to put their question, ask the audience to type in the question on the chat box. Okay, thank you.
Yeah,
okay, fine.
Feel free to put those questions in as we go, because yeah, it's a really good point. We can stop and answer them if they're before moving on. Thank you so much, Sarah.
That's okay. This is my other program of work. So my one program of work looks back in childhood, so things you can't change, but we're learning resilience in that area as well. But this is modifiable risk factors for dementia and cognitive change over the life course. So what can you do about your lifestyle that will change those trajectories? So some of you may be familiar with the Lancet report of 2020 that showed this wonderful figure that 40% of dementia risk is actually modifiable. And of that 40%, it's lower education, hearing loss, traumatic brain injury, hypertension, alcohol misuse, obesity, smoking, depression, social isolation, physical inactivity, air pollution, and diabetes. And that might be a long list to look at. Did a press conference the other day and they said, is this just another list you scientists are going to give us? And we've got to walk around and think, oh, tick that, tick that. But no, if we start to look at this list, a lot of these overlap. And the interest of my work here in Oxford is actually to look at hearing loss, which you can see is over 8% of that 40% risk. And hearing loss actually has an impact, a real significant impact on depression and social isolation. So really, we're looking at a major thing that you can do something about and the impact again on mental health. So if we look closer at hearing loss, we can actually also affect in a positive way or prevent traumatic brain injury through falling, because if you fix elderly people's hearing loss, it fixes their balance and hopefully prevents falls. Also, people who have hearing loss and don't wear their hearing aids tend to not go outside, their social circle shuts down, they get less exercise, they're more prone to obesity, physical inactivity, and diabetes. So the focus of my program of work is on hearing loss and hearing aid use and promoting the use of hearing aid. So our recently published work showed that hearing aid users were less likely to develop MCI, mild cognitive impairment, than hearing impaired users who did not use their hearing aids, with a 52% risk. Again, this was in the National Alzheimer's Coordinating Center cohort, or the NAC cohort, of 4,000 individuals longitudinally over 4 waves. And then our second study showed that those with MCI and hearing impairment had a reduced risk of progression to dementia if they simply wore their hearing aids, 19 versus 33%. And this was on a sample size in the NAP cohort of 5,000. If you look at these figures here, it shows you just how effective hearing aids are. The top shows scenario 1, which is a normal hearing person with hearing impairment and cognitive trajectories over time, with the person in red with hearing impairment declining much quicker than those with normal hearing. The second graph shows those who use these are both hearing impaired, but compares those who wear a hearing aid with those who do not. So you can see that decline in the red, showing those who do not wear their hearing aid. And importantly, the third one shows those with normal hearing, those with hearing impairment who simply wear their hearing aids. And you can see that it brings the trajectories almost to the same point, just simply by wearing a hearing aid. So really, if we start to address hearing loss and promote going for hearing tests at a much younger age and destigmatize that and say, well, it's normal to have a hearing test in your 30s. It's not so bad to wear a hearing aid and fix it in your 30s and 40s, rather than waiting till people are 65, which is usually when hearing loss is promoted and go and have a hearing aid fitted. And we're also looking into difficulties of people, why they don't wear hearing aid, and hopefully creating a better path rather than the top path. Yes, you've got hearing aid, read this pamphlet, hopefully go get a hearing aid. We're hoping to get funding to fund a much more interactive educational path for people of all ages and disabilities to promote hearing aid use to prevent dementia. So my last section of my talk today is on what is DPUK doing for early career researchers. Now, we identified that a lot of researchers were coming along to DPUK. It's a bit like a candy shop. They were submitting an application, applying for 3, 6, 9, even 10 cohorts. And then after a year, these projects were standing still. I was doing mentoring as much as I could, but we found that researchers were just not used to handling multi-cohorts and cohorts of 500,000. They just simply didn't know what to do with them. So we decided to start training researchers ourselves. We started with datathons back in 2017. And these, pre-COVID, used to be a 3-day workshop event where researchers would come along, and this is industry, academia, pharma, will come along, and we would give them 6 data sets to work with on the data portal in groups and with a research question. And then for 3 months afterwards, I would mentor them to get a paper out of their research studies. And then during COVID, we simply took it online, and now we're going to keep them online because it has a more broad international reach if we keep them online. And this has been really, really popular. We have another one coming up in a few weeks' time. And this gave people the opportunity to really see what a large cohort data set looked like. But, here I spoke about my slide and didn't switch on. So we had a scientific theme. We have 6 cohorts who've agreed to work with us on this. They all get access to a virtual desktop. They work in their teams, and they love to give a presentation at the end showing how far they got with their analyses or research question. So hugely popular with ECRs. And then we decided we really needed to do training as well. This was feedback from our datathons. Researchers were saying it's all fun, but how do I get training that is affordable? So we've designed 2 different academies. We have a spring academy for beginner researchers, and this is really aimed at people who last did analyses in their undergrad and they need a refresher course, or perhaps clinicians who have never done statistical analyses. So this is all online, so it can be reached by anyone, no matter where they are in the world. We're in our second year of offering these academies. The Autumn Academy is for advanced analytics. So we have 1 day on structural equation modeling, 1 on survival analysis, 1 on machine learning, and 1 on time series work. So we hopefully are really trying to cover bases, and all we charge is £100 for 5 days training, which most researchers can find, and this money goes towards paying our lecturers a gratuity at the end of the workshop. We also have a researcher hub. We're busy launching this right now. It is live, but it's not technically formally launched, where researchers can join the hub. They get to know about DPUK. We're building a community of researchers across the world, and we're linking to other training portals as well. I've already spoken to the training arm of IHCC. So at the moment we have AR UK's portal here. We could have an IHCC portal link in down here. We have we have help documentation for researchers accessing. We have videos online, which we're going to be linking up. We also have a mentoring hub where people who want to be mentored can sign up, and mentors can sign up. So we're promoting this amongst senior academics. Please sign up. Put down your specialist area of interest. Do you want to mentor a group or one-on-one? And so this will be properly launched over the next few months. This is the community forum within that hub, and you can see we have different tabs for different areas of for the researchers. And I'm done. I thought I did my timing quite well. Thank you. Any questions?
I thought your timing was exceptional. So I'm going to use moderator discretion and ask a couple of questions myself, and then encourage others to put questions into the chat, please. So I haven't heard anyone juxtapose, standardize, and harmonize right together like that, and I really had sort of an aha moment around, do not let the perfect be the enemy of the good here, and the ability for you to have rigor around these large populations with a little bit of adjustment, because the questionnaire you used a childhood abuse as an example of how to get those all kind of together. And I guess I was just really struck by that and wondered if there are lessons for other studies that are using different kinds of data. I don't know. I'm trying to, of course, I think of genetic data or other kinds of phenotypic data. Yeah.
Yes, so I think that that we found that a lot of people, as you said, the confusion over standardization and harmonization is there, and also the confusion about when to use it and when it's not really necessary. And I think 5-6 years ago, when we were starting to say this, we got a lot of pushback from the research community, I have to say. But I think as it's matured and as people have got to understand large cohort data work more, it's appreciative of the benefit of both. So we're not saying never harmonize.
Right.
Because in our IHCC grant, NIH grant that we've just applied for, we're going to be doing both. Right. But there is a time and place for both. We are also going to be standardizing genomic and imaging data. We're standardizing the pipelines that are coming into DPUK to try and help non-specialist researchers access multimodal data sources.
Oh, it's fantastic, that mentoring component. I'll let Rongling ask her question. Please go ahead and come off mute. Go for it.
Yeah. Thank you so much, Cindy. Sarah, it's a great presentation, and it's wonderful. It's the DPUK like a model for IHCC to follow. You have the data infrastructure and you put everything together, and you don't need people to download the data to analyze data. You have science included in it, and you have training for people to use this data and use these resources for research, for scientific studies, which is wonderful. I hope that IHCC can do the same thing in the future and ready to bring all the scientists from all the world to do the science. And also, I know that IHCC we have now 70 or more than 70 cohorts. If we can use the similar approaches like a DPUK, I'm sure that all these resources can be widely used and the scientists will appreciate. Thank you so much. I don't have exactly question about your contents, but I really like the framework and all this infrastructure you have built up already. Thank you so much.
No, that's a pleasure. And I think that we have just worked with the Cosmic Consortium in Australia, Paminda Sachdev, to help set up Dementias Platform Australia and they've piggybacked on DPUK, and we've helped set them up. We're helping a Dementias Platform Korea. And likewise, you know, if we can help IHCC achieve what they want to achieve, it will, you know, you don't have to work on it for 7 years. If we've got a model that will help IHCC, I think that's fantastic collaborative opportunity.
Oh, it's exciting. Katerina, please go ahead.
Yes. Well, I'm sorry, thank you very much. This very important conference for us. Besides everything said wrongly, I wonder, we are very behind with our cohort in Chile in the way of sharing. We are doing the same, but like a homemade system based on our studio. So we prepare a database for the participants, but it's not very flexible because they have to work in R, you know. So I would like to know more, but maybe not today, about how if we can copy your system somehow, and you know, the cost involved and things like that, just to make the access to our data more flexible for. And the other question, the training, I think is, I mean, the best thing that you can imagine for us will be great. The problem, for some reason in Chile, all the people who work in statistics and informatics around us, they don't speak English. So I wonder if you have something for non-English speaking, some facility, or you have someone there that can help with that. And these are my questions. Thank you. Thank you very much.
Yes, well, we would very much be very happy to work with you and help you in any way we can. So we've got a video about the data portal, which I'm about to update for Australia because they need it. And one way we can do this is to get it translated and have subtitles. And because I think, as you said, not everyone is, especially early career researchers, they're not always fluent in English. And so I think that is really, we're trying to branch out, we're trying to make it accessible, but definitely that is something that we need to do. Thank you. Do contact me directly and I can set up a meeting.
Okay, thank you, Sarah.
Okay.
I'm curious also, if no one else has got another question, I'm really curious about this hearing loss and its effect on cognitive decline, and whether there's has it been postulated that there might be, I mean, I think the mechanisms that you talked about make a lot of sense about they start to, you know, sort of sequester into their homes and don't go out as much, which is going to have consequences on their mobility and their strength and all of that. But I also think that learning is such a big part of brain health, and that maybe if there aren't ways to hear and you're used to learning through hearing, if that isn't also contributing. And I wondered what your thoughts are on that.
Yes, so that's really part of our new phase of work, is to understand that more and to understand what part of the brain function is particularly implicated in with hearing loss. And so I'm applying for funding to progress this work, but there's very limited work already been done, but the limited work that has been done is looking at the fact that someone who starts to lose their hearing, who's always had perfect hearing, they're focusing so hard on trying to hear that they're neglecting their cognitive resources. So all the brain function, it's a bit like someone with depression. All the brain function is focused on coping with depression, that the cognition starts to go. And so it's this hypothesis that this is the link, but also the associated effects, the social isolation, the depression that goes with hearing loss is very significant. So hopefully in ongoing work, I must say funded by Alzheimer's Research UK, we'll be able to understand this much better.
Yeah, and I mean, even something so just thinking back in your early adversity work, something such as you've been able to characterize sort of the populations that are affected by early adversity. You know, is that a tool that could be used in stratifying populations going into a clinical trial around depression? Because you've also made associations, I should say, with these particularly these brain areas that seem to be implicated in these. And I just think it has a lot of opportunity for therapeutics potentially.
Definitely. So a lot of people say to me, oh dear, that's very sad news. You've got a very sad program. You know, I can't go back and undo my childhood. Yeah. But Morgane, from Switzerland, her 2-year fellowship is to develop a risk resilience tool. And so really it's to understand, because some people have a really hard start in life, but it doesn't have a negative impact. So what we want to do is understand those who do and those who don't. So by understanding resilience, as you said, a tool such as this can be invaluable for understanding disease progression.
Yeah, it makes sense. And this is Morgane, who only had 73,000 participants. Like I heard that number and I thought, isn't it funny that we say only these days when you've got, I mean, it's fantastic. So I think this might be the last question we have time for. Carlos,
sorry, there is another question on the chat. By Carlos.
That's what I'm looking at. So Carlos's question, and Carlos, you're welcome to pop in and ask it yourself if you prefer. But if not, I'll go ahead and ask it. So he asks, have you assessed changes in odds of cognitive impairment with educational attainment, especially in populations that have reported high dropout rates at low educational levels? For example, less than 6 years of education. And then he goes on to give an example. So for example, in Mexico, high rates of dropout has been related to economic problems and family violence, and they've had the necessity to drop out of school for those and other reasons.
Yeah, I think that this is a very good point. And I have a postdoc who's working with the Lassi-Dad cohort from India. And in India, there, you know, I worked in a hospital once, falls risk, and you've got ladies having 2 years of education because they weren't allowed to go to education. So there was even less. So in addition to drop out for those reasons, you have people who culturally don't have much education. And I think it's really important to look at this almost as a subpopulation. So Carlos, I think this is really important work.
Very, very nice. It looks like we've got a couple more messages. Okay. And
actually, this is just the announcements. I can say it's when we finished.
What I think we're winding up. I think that's the end of the questions that I see, and I got to ask all mine, so I'm very happy. But Sarah, fantastic presentation. Thank you so much. I'm happy to have been on with you in this. And then Latifa, I'll let you make your announcements.
Okay,
Thank you.
thank you so much. Thank you, everyone, for your participation in this session. And thank you, Cindy, for moderating this session, and Sarah for the insightful presentation. So I just would like to announce the upcoming webinar series talk that's going to be by you, Cindy Lolly. So our moderator, she's the one who's going to be presenting the next webinar on June 27th at 9 a.m. EST. And the talk is going to be the utility of broad-scale proteomics in large population cohort studies. So please mark your calendar for these events, and looking forward to your participation. And Sarah, looking forward to our collaboration with you for remote mentorship program using DPUK platform very soon. We can talk about this during our next meeting. So thank you again, everyone.
Thanks, everyone. Thanks again, Sarah.
Thank you, Sarah. That's wonderful. I hope you can present that at the sixth summit of the IHCC, and more people can understand and know how to do this.
Yes, I'm always
Okay.
happy to talk.
Okay,
you.
great.
Bye-bye.
Thank you.
Thank you.
Bye.
Bye.
Thank you.
Bye,
Thank you
everyone.
very much. Bye bye.